I can see people are joining us now. Thank you all for joining us today. We'll let folks sign on and we'll be starting in just a minute. Welcome, everyone. I'm Denny Brennan. I'm the Executive Director and Chief Executive Officer for the Massachusetts Health Data Consortium. I'm very excited to welcome you to this month's Executive Forum devoted to the road to interoperability. Before we introduce you to our forum co-chairs and guest experts, let me go over a couple of housekeeping items. We have an hour slated for our discussion this morning, but we also have an optional 30-minute discussion period afterwards. If you're able to attend and join us, and some, if not all of our guests, certainly our guests are welcome to join us. We don't require it, but we've always found these after sessions to be open and thoughtful and thought-provoking. So that's an opportunity for everyone to share questions and get further into the meat of what we're talking about today. Please share your thoughts and questions verbally. You can use the chat, but we call it a forum because we like people to talk and interact. We're trying in some respects to virtually recreate what we used to do as a consortium in our forum, where we would bring people together and there was this camaraderie and collective participation around the table. Sitting around a virtual table, we have to try to work on a little harder, but we hope we can do some of that today. The recording for today's session will be available on the MHDC website within the next 24 to 48 hours. And as you leave this the session today, please take a moment to complete the very brief Zoom survey that will come up at the end. All right, now let me introduce our co-chair, Bill Young from Berkshire Health Systems. David Crucio is not joining us today. Welcome, Bill.
Good morning, Denny, and good morning, everyone. Thank you for joining us. On behalf of our chairman, David Crucio, I again want to welcome you and thank you for joining us. It's great to have such amazing industry experts to share their thoughts and ideas with us. As Denny said, I really encourage you all to participate. These sessions go so much better when folks speak up, interact, and talk. So again, thank you for joining. Welcome you all. And please, if you can, take time to join us for our remaining sessions throughout the year. But with that, I'll turn it back over to Denny and introduce our guest experts.
Thank you, Bill. Joining us today are three experts in the discussion that we'll be sharing, which is the health data economy, the app ecosystem. Joining us today first is Jennifer Blumenthal. Jennifer is a highly accomplished product director with Milliman IntelliScript and is specialized in developing cutting-edge solutions that facilitate the secure delivery of electronic health records. With a strong focus on consent-driven insurance underwriting and clinical trials, Jennifer spearheads the implementation of innovative technologies in compliance with industry regulations such as the 21st Century Cures Act, TEFCA, and FHIR APIs. Also joining us today is Graham Dufault. Graham is the General Counsel with ACT, the App Association, where Graham leads the App Association's legislative advocacy efforts on issues including privacy, digital health, antitrust, intellectual property, and related issues. Prior to joining the App Association, Graham was counsel for the House Energy and Commerce Committee. Jill DeGraff is the Vice President of Regulatory at b.well Connected Health, where she serves as an internal customer and industry resource and subject matter expert in data access, consent, privacy, and the regulations characterizing the shift to consumer empowerment and value. Jill is an expert in the regulatory and operational aspects of health data connections through FHIR APIs and health information networks, as well as navigating the privacy and compliance landscape where health-related apps operate. So thank you to our guests and welcome to our executive forum. All right, we conduct the executive forum with 4 questions. And what we do for the benefit of those who are joining us today is we ask our panelists, our esteemed guests, each of these 4 questions. We get their input, and after each question, we go to the audience. So with this first question, we'll speak to our panelists, and then we'll turn to the audience to get your questions, your thoughts, your perspectives, and then we'll move to the questions that follow. So why don't we start with this question? What are some of the major types of data that patients want, or the tasks you see patients interested in doing through health-related third-party apps? Are there barriers to implementing them in the current healthcare ecosystem? Jennifer, why don't we start with you? You are on mute. There you go. Okay.
Thank you. So for background, OneRecord is a patient-facing application that I built. OneRecord was recently acquired by Blumenthal. So I have a lot of experience in building a direct-to-consumer application that empowers consumers to access, aggregate, and share their healthcare data. Over the years, kind of the major themes that I saw with consumers wanting to access their data was they were really looking to get data from provider organizations that they saw a very long time ago, and they maybe forgot about how to get that data. I saw a doctor 10 years ago, how do I get that data? You see a lot of people looking for records around their birth or family history, kind of trying to put the pieces together. I think the biggest use case that you see are people kind of going through a diagnosis journey. So that person who's just been diagnosed and they're going from doctor to doctor, trying to find like the right treatment plan, and they're trying to collect that information as they go. You see a lot of administrative use cases. So people needing to get their records for maybe disability or something along those lines. During COVID, it was all about vaccines and immunizations. And then I think the last category are people managing the care of themselves, potentially their children and their parents. So I think of them as the sandwich generation. There's one data element that we can't access today is imaging. That comes up all the time, is people really want access to their imaging so that it's portable and they can take it to them to get, second opinions and things of that sort. I'll come back to all those.
Oh, we're going to come back to that, I'm sure. I'm looking forward to it. Jill, what about from your perspective?
Well, thank you very much, first of all, for having me today. This is a great set of topics. I also love the fact that you've got nested 2 very meaty questions in this first question.
We do that. We like to throw those curveballs at you.
So for perspective, b.well Connected Health operates a platform for consumer health applications. We sell to HIPAA-covered entities, health plans, employers, retail pharmacy, health systems, and all of them are looking for an opportunity to deliver a more consumer-centered digital experience. And for that, all types of data that is already fragmented across the realms that reflect the healthcare system is what we believe patients want. I am a caregiver, for older young adults and also for an 83-year-old mom. And so in my case, the information that I need will oftentimes be very episodic depending on a particular need. I'm grateful to be able to find information when I dig in 8 years or back into a My Chart, but it's not easy to get. The information that I need is whatever is relevant and important to me at that point on a clinical basis. But it's also important to think about how data is just that, but not insight and information unless you can start pulling it all together from multiple streams, because it is fragmented. So if you can imagine a situation where someone goes to an encounter and then gets a script and then has that script filled and that script is adjudicated, all of that information is ultimately available from different sources, your even the eligibility for that data. And so it's all, from a retail pharmacy, it's from a health plan, it's from your doctor. And if you can have it all together in a single, as a represented as a single event, now you're actually trying to meet a patient where they are and they can start doing something with it. Now you start multiplying that by all the different events and all those streams being able to come together as a unified longitudinal health record. And not only are you able to make it more comprehensible to a patient and allow a lot of different insights that they drive, but you're also able to start building automated insights so that you don't have to, require investment from your patients into your application. I always say the best healthcare I have is the healthcare I never need. But when you need it, you want to make it easily accessible and comprehensible for the patients. So being able to bring as much data as possible forward and allow the kind of personalization that is made available when you have that abundant data in streams that's all connected and in real time, that's where there's value.
Terrific, thank you. Graham, I think the second question in this is probably one you look at and you hear about a lot in your work, but certainly with respect to both questions here, what are your thoughts about this?
Yeah, well, first of all, thank you for having me. And the App Association is a trade group, so we represent software developers, connected device companies, but such a growing percentage of them are working in digital health that we created a connected health initiative separately to advocate, specifically on healthcare coverage, healthcare privacy, interoperability, and all the things that Congress and the agencies are working on right now. And so I really appreciate being here in the invite. It is the first question is an especially tough one for me because as Jill and Jennifer both alluded to, pretty much any data point can be relevant to a caregiver or to a consumer with respect to their healthcare, depending on the context. And one of the challenges that we faced, earlier last Congress, the 117th Congress, and then this Congress, as the committees of jurisdiction were working on perfecting value-based care and trying to shift the Medicare system, for example, to value-based care was what is a definition of social determinants of health that we could work with, and having a statutory definition may not be the best way to go, but at least there are elements of it, right? So at any given time, your access to broadband can affect your healthcare. Whether or not you live in an area that's considered a food desert or close to being a food desert might affect your healthcare directly, and so. To patients and to consumers, a lot of different data points can be useful. And anecdotally, you've had a number of folks talk about the need to be able to transmit data about their sleep or just really basic, whether or not they're moving all the time, their heart rate data. There's one anecdote in particular that sticks in my mind. We have a member company founded by a PhD MD who shared this story with legislative offices and regulators last time we had our fly-in, where her husband had just come home from heart surgery, and during the night he had an episode and he woke up feeling horrible, and wasn't really sure what happened, but his smartwatch recorded that he had essentially gone into AFib at like 2:30 in the morning. And so they were able to communicate that to the ER doc and basically get in and get care quickly. And the way she tells the story is that the ER doc was like, wow, this is the future of healthcare. And she said, no, this is the present. If we can enable patients to make use of data like heart rate data and all of the really useful stuff that can be collected by sensors. And so the answer for me is it can be pretty much any data point. The question is whether or not we can make it useful for patients and legible for patients at a consumer level, And can we also adequately protect it, find a way for the legal apparatus to adequately secure it against unauthorized access, and then ensure that people are not going to misuse it, which is unfortunately what we see a lot in headlines. So I'll stop there. And I know there was a question that we can, yeah.
I'm going to turn this back to Jen for a second. Jen, you've talked a lot in your prior life about some of the barriers to implementing, this kind of connectivity for consumers and this kind of access for consumers. And in those comments, you painted a pretty clear picture of the state of things today. Could you talk a little bit about where we are and what are some of the major points of friction or difficulties that consumers encounter in accessing their health data?
Yeah, so that's a great question. To me, there's two things, right? There's the developer experience to empower consumers, and then there's the actual patient experience to access their data. So I'm going to start with the patient experience to access their data, and then I'll talk about the developer. So right now, for a consumer to access their data under 21st Century Cures Act, it's still pretty limited to the use of FHIR APIs, reusing a set of credentials that are given to them by a provider organization or a health plan for them to go in through an OAuth workflow. So for anyone who doesn't know what that means, it's kind of like log in with Facebook, log in with Google. You're using this an OAuth workflow to essentially identify who you are and match it to an internal identifier within the system that you're connecting to pull your healthcare data. The number one issue for people is going to be like, hey, do I remember my username and password, right? But then they have to, if they want to aggregate all their data, do that 10 times to get data from everywhere. But let's say they're successful in actually authenticating and the application of their choice actually can support all the places that they've received care. Then the things that they're going to run into are authentication errors, token failures, which are part of the OAuth workflow, not getting back any data. Most recently, we've been actually running a paid testing of all the health plans that we're connected to. We're connected to over 400 health plans. And what we're seeing is a lot of the data that we expect to get back for the mandated lines of business under 9115, we're not seeing EOBs or patient resources come back. So the user experience is kind of like going through some sort of epic video game journey of like, can I get to my data? And when I get there, is it actually there, right? So that's just like the user experience. An ideal user experience is where you actually use your demographics and you query a responding system, and then the responding system says, hey, I have your records from multiple facilities or within maybe a system or across hubs. So think of more like an HIE model, or being able to participate on national networks like Care Quality or Commonwealth, or in a future state, TEFCA. So that's kind of the consumer experience. I would say it's still pretty limited. So enabled to really have risk around consumers accessing their data, we haven't reached that tipping point yet. We've just gotten started because most of the compliance dates for only kind of rolled out in the past 2 years. So health plans had to make the data available July 1st of 2021, and certified technology vendors who support providers had to make the data available starting for our 4 FHIR APIs December 31st, 2022. So really January 1st, right? On the developer side, that's really, I think, the barrier for empowering consumers with their data, because on the developer side, what you're dealing with is, so if you take the provider side of the organizations, on Chapel, which is where it lists all the certified technology vendors, there's about 200 products/vendors listed, and all those vendors are supposed to list their FHIR URLs, so the unique addresses for their clients that they represent, whether it's universal or more specific to that organization. Only 33 of the 200 have listed. So there's 167 who are technically out of compliance. And most of those organizations, even though they certify to being able to support patient access APIs, they are not production ready at all. So only the top 10 vendors in my mind have been able to hit that milestone. And then the long tail of interoperability is still just as fragmented as it is today. So that will be really the journey of like, can we get providers and their supporting EHR vendors to open up that data by actually making their FHIR APIs production ready. On the health plan side, I'm going to stop in a second. On the health plan side.
No, you're on a roll. Keep going.
On the health plan side, what we saw, the summer of 2021, and Jill and I talk about this a lot, was the health plans were not prepared for this, right? Like they kind of rushed up to this compliance date, and then nobody requested except OneRecord. We were aggressive about requesting as many health plans, but it would take 6 months to a year to maybe go live with certain ones. Some of them we can do in a day based off the production readiness of those FHIR APIs. But there's limitation in the health plan FHIR APIs because they're only for the mandated lines of business. So most of our users coming through a direct to consumer application are trying to connect to commercial, the commercial lines of business or the employer sponsored lines of business, and they get failures. They can authenticate, but they can't get their data. So right now we still have this really fragmented user experience and able to build like the digital center of care for consumers. And, there's no penalties right now on either side. So until the penalties come out, there's not going to be that much of a need. I mean, I literally stock health systems and health plans to make their APIs better. And some of them send me cease and desist letters, and some of them just stop responding me altogether. So the success in order to connect to an organization's FHIR API really depends on their level of education, their willingness. But Jill and I send her emails all the time about this. I get the most ridiculous responses about privacy and security and HIPAA and security questionnaires. I mean, it is a giant lift. It's like a Godzilla size lift in order to connect to FHIR APIs. I actually have a Godzilla stuffed animal that someone gave me to show the.
I remember a year ago, Jennifer sending me a maybe 10 or 11 tab long Excel spreadsheet, basically equivalent to a security risk assessment that a health plan would offer in a vendor of choice selection RFP. And that was what they were asking a third-party app developer to complete.
I had a smaller EHR company the other day. The smaller EHRs are interesting. These are like specialty ambulatory, they got on the line and you can tell 3 of the people had been the ones built the FHIR APIs and 1 person was new. And he's like, oh, we need an NDA. We need a BAA. We can't answer these questions. You're trying to reverse engineer what we built. I'm like, no, I'm trying to understand if you actually built it correctly. So there is definitely a lot of education that needs to happen on the cert technology provider side. I think the health plan side is it's further ahead right now just because of companies like myself requesting access. But there are still a lot of health plans who have not connected to a third-party application or haven't made their FHIR API available because of issues with their underlying service provider. So if they outsource to a third-party FHIR server vendor or other things. So that's my spiel on this topic.
Yeah,
well, go ahead, Jill. Go ahead.
Yeah, and I'll try to follow that same kind of framing. So from the consumer side, everything you said around portalitis, big drop-offs because people can't always remember all their patient portals, and then there may be some kind of an update to the API that is not communicated to the developer, and so the token breaks and then the data isn't coming through. Oftentimes as well, the access token may be so short-lived and there's a failure that we have to engage the consumer again and again and again in a troubleshooting call that has to be scheduled, in an attenuated fashion, just to be told, oh, this user is a commercial plan user. We didn't make that clear in the calls, but we're not making their data accessible. So it's a very poor experience for your members if you're a health plan, and that member is a member of commercial. So a concept here is that is a frictionful experience. It's on portalitis, but it also is, we've got more than 51% of the country that's on commercial plans, and they don't have access to their data. You have to be on the plan side. You have to be in a CMS program and have that data accessible. What I would also say is that on the developer side, and I'll Roger in as well on the issue of compliance on the clinical API side. There are not a lot of, there's just not a lot of transparency in what we call this whole point around endpoint discovery, so that we as developers can discover where those APIs are, who the authorizations are. And oftentimes there's a little bit of Abbott and Costello going on. It's like, oh no, you have to go talk to the provider in this digital point of contact for access, but then and we're talking to the interoperability vendor and they're not telling us who that person is or putting us in touch with them because they think that that is a violation of their confidentiality obligations. It's kind of ludicrous. And I'll just sort of stop there. At the end of the day, what we want to, where we're seeing a slower uptake is for all the ambulatory and for on-prem kind of URLs. If you have, if the EMR vendor that a health system is using is really implementing through some kind of a gateway, it is a much simpler process for us to find those URLs and be able to make those connections. I would like to also shift over to the network side of things. So again, as a barrier, just conceptual barrier, the idea around network-based exchange for the patient use case is dictated by the concept of patient match at a deterministic 100% level. And so there are a lot of different standards around that, but everyone is sort of in agreement on the idea of getting an IAL2 compliant proof of identity verification for the individual before asserting that patient access request. But even so, the standard response rate is under 5%. Some people say it's 16%. It's still very low. And the reason is the risk of breach, maybe also because of the risk of, fat fingering and bad, just risks at the data holder side. But what we are really needing is a situation where under trust arrangements, like a common agreement under TEFCA, even with a Commonwealth Alliance, if an individual access service provider undertakes certain steps to, so that there is a low probability of compromise, so that the data, so that we could get to a place where there's more probabilistic match with individual access service providers that are not HIPAA covered entities or business associates, but nonetheless under a trust agreement in a verified way promise to take certain safeguards to prevent redisclosure, then I think if we can get the OCR to move towards a kind of guideline or safe harbor that allows for that, then we would be able to see a way of not having to use patient portal credentials anymore, and instead use some kind of a FHIR facilitated network-based exchange or query-based exchange today in order to get higher record response rates for patient access.
Graham, I want to come back to you about OCR. I saw you nod your head and perk up about that for a moment there. I could tell you wanted to speak up. But let me say that Chris in our audience is raising his or her hand. Chris, do you want to ask your question?
Yeah, sure. It's not really asking a question as much as it's just kind of speaking up in, I don't want to say defense of the payer community, but I understand Jen's feelings on, not being able to get access and connectivity. And, so full disclosure, I'm the solution architect at Massachusetts, Blue Cross Blue Shield of Massachusetts, and was responsible for standing up the patient access API, provider directory API. And when I first got there a few years ago, really FHIR wasn't anything that people really comprehended. There was some difficulty in really deciphering what it was that we had to build. So, but however, I think slowly moving forward, the stuff that we're looking at building out in the future is going to be FHIR compliant. And my suspicion is this next mandate that's coming in 2026 is going to directly impact the way providers and payers work with each other. And there's going to be some requirements to do prior authorization and then some HEDIS reporting, actually, which comes this year, which is going to be really influence how providers and payers are more in tune with using common standards and sharing data electronically.
Hey, Chris, I actually agree with you on the on the payer side. I'm more on my provider side kick right now.
Well, I need the provider data. Like I've got so many things coming that I have to figure out how to do that. You know what I'm saying? So
we can talk offline about that, but
okay.
I do think I acknowledge that the payers, this was their first like down the rabbit hole into interoperability, like the provider and sector technology vendor, like they've had to do MU many years over. So like they did meaningful use all 1, 2, 3, right? I do see that. And what I do find actually on the health plan side is, even though in the beginning it was super rough, they're actually way more willing to work with us. And really the consumer app, our consumer app, was a real world testing application for a lot of health plans to see how their data that they converted into a FHIR format would represent within a UI, right? FHIR doesn't have context. It doesn't have structure. It's not a structured document. So there's decisions on how that's going to represent. And a lot of health plans still use the application today as they're rolling out or thinking about additional resources beyond R4, R5, whatever the different versions are going to be for USCDI as well. So if I came off as I'm harping on health plans, I'm actually not. I'm more on the EHR and provider harp this year.
Yeah, I mean,
Graham,
it's
I'm sorry. Go ahead, Chris.
Sorry, yeah, I totally get it. You know, the providers, they just say, well, toss it over the wall to Epic, right? Let Epic figure it out. So, and I'm totally get that. And Epic just wants to sell their payer portal, right? So, yeah, we should definitely chat more in the future.
Graham, just before we move on to the next question, I wanted to make sure you had your perspective shared on this.
Just a super quick point to note that you know, we did have a meeting recently with ONC, and without characterizing anything that they told us, on our side, what we sort of acknowledged that ONC had asked Congress for this new authority to charge people for sort of an opinion about whether or not what they're doing constitutes information blocking, or just to present a scenario. DOJ has this authority, the SEC has this authority. Their issue, you know, is going to be resources, the ability to investigate instances of potential information blocking and then refer it over to OCR. So they have some difficulties to figure out, as you know, as ONC looks at the issues and looks at the fact pattern and then refers it to OCR, which is in charge of enforcement. So right now their question is before, and as Jennifer alluded to, they still haven't started enforcing it because they have to come out with that civil monetary penalty rule from OIG, yet another sub-agency. So part of our job at my organization is to make sure that the agency is working hard to organize itself across these sub-agencies to make sure that they're all speaking the same language and defining things the same way when it comes to information blocking. And you know, and in the meantime, they are, you know, making sure that they're not sort of waiting for Congress to give them additional authorities to do this stuff, because it needs to be enforced like right now, yesterday. As one of our member companies said to ONC, I'll come in and intern for free to help you investigate these things. So that's sort of the, not desperation level, but something like that among our membership.
Well, I think the second question is going to move us into this a little more specifically, or at least part of this. And Graham, I want to direct this to you first and then to our other panelists. There is some concern that third-party apps aren't subject to HIPAA. We know that the FTC has some regulatory authority, but are there additional regulations you think would improve the ability to give patients the data and features they want while still preserving privacy and other aspects of data governance and controls? So this seems to follow on what you were just describing, is who's on first, who's on second, who's on third, and how does this get done from an agency perspective? Can you tell us a little bit about this, especially as it relates to privacy?
Definitely. I think there is a lot of concern among HIPAA covered entities and business associates as patients seek access to their own data and try to pull it outside of the HIPAA umbrella. And they kind of worry, you know, that's always described in the press and elsewhere as sort of the Wild West. And the FTC really is, it is not a regulatory agency. It has the FTC Act, and it's an enforcement agency. And so that's a double-edged sword. It gives them really broad authority on the one hand, but on the other hand, they don't have first offense civil penalty authority usually. The reason that it's sort of tried to shoehorn this health breach notification rule into circumstances where it wasn't really written for is that if you violate a rule under the FTC Act, then you're subject to civil penalties immediately. But if you don't, and you just, liable for an unfair or deceptive act or practice under the general statute, then the FTC only has injunction authority, and they can't charge you money in the first offense. The reason they got $5 billion from Facebook is because Facebook was under a consent order and they violated the consent order. And that's why they were able to get such a huge penalty out of that company. But the problem that we're facing right now has a lot to do with sort of the headline driven concern around health apps accidentally or on purpose, or maybe some parts of the company know about it and other parts don't, where they've used a Facebook SDK, the software development kit that is training Facebook's ad algorithm. And and meanwhile, their privacy policy says, no, we're not sharing your sensitive personal information with third parties. So that's illegal under current law. That's illegal under the FTC Act, and it's illegal under state mini FTC Acts, and certainly under the 9, maybe 10 state privacy laws that have been enacted, which treat sensitive personal information as subject to, express affirmative opt-in consent, and health data applies to that. So it's not the Wild West, but it is a different system, and folks that are under HIPAA don't understand it very well, and vice versa. So what could be done is, and we've been working with Congress on this for a few years now, is to enact just a federal privacy law that's sort of patterned off of what the states have been doing, where sensitive personal information would be subject to express affirmative consent, and other restrictions would apply, impact assessments, and data minimization requirements, which actually would go a little bit further than what the states have done so far. But this is what we're pursuing right now, and we view it as sort of an alternative to some of the other, bills out there that would say, now OCR would be responsible for policing the rest of the world. Everything is potentially health data and should be subject to HIPAA, and that's we would rather have an approach that puts the FTC sort of in charge of policing conduct, privacy conduct, and data security and stuff like that in the general economy.
Jill, how about you? Go ahead.
Yeah, well, I want to say, both b.well through the applications that we provision that provide PHR capabilities, and OneRecord, which is, previously direct to consumer, but always, focused on consumer consented access and use of data. Like we're part of the good guys in terms of trusted third-party apps in the Cures Act. And also even before that, when the HIPAA rules were updated in 2013, it was very clear that the issue of individuals having the right to access their data through any mechanism, even unsecured, is in patients' rights. And really that became the, my boss often will say that the patient right of access became the 4th permitted use case under HIPAA because of the Cures Act. And so what we're seeing is, and I'm thinking about a year ago, there being a lawyers committee that was trying to slow roll the requirements for third-party apps to be able to even have access because of concerns by covered entities about what those third-party apps are going to do. We can all have those concerns, feel that concern, but at the same time, you can't superimpose your own concerns as a covered entity or business associate in a way that would interfere with an individual's right of access. The information blocking rule commentary is very clear about that. What we actually end up seeing, just in terms of another barrier, is oftentimes some educational screens within the OAuth workflow through these connections to authorize data flowing to third-party apps are what we call red murder screens of death. There are mischaracterizations of the privacy practices of all third-party apps or just of a particular third-party app, and that's simply not appropriate. And the CMS proposed rule is very clear that it does not have authority, statutory authority, to regulate third-party apps that are helping patients connect to their data. And as a result, HIPAA-covered entities and their business associates do not have that authority. So I do want to make sure that while we can all have those concerns and we can listen to Graham about what kind of rulemaking response or legislative responses are possible, that you nonetheless put yourself into a very into some jeopardy if you try to create if you interfere with third-party apps access or ability to connect to your via endpoints.
I think from just trying to build a consumer app, first of all, if I could go back in time, I'm not sure I would have ever gone down this journey because I didn't know how hard it was going to be and all the twists and turns to do it. But, you know, and like, you know, this is 6 years ago now, coming up on 7. So the way that we operated from the beginning is we took the privacy and security rules very seriously and we try and follow them. But if we become regulated, if we fall under HIPAA going forward, I mean, you're never going to see any adoption of consumers accessing their data by true direct-to-consumer applications. It's going to be too hard. There's too much compliance. You're going to go from HIPAA, you're going to need a high trust, you're going to need so much to just answer those security questionnaires to even get data. I think what will end up happening is you won't ever see anything that is direct to consumer living in the App Store. You're just going to be seeing covered entities utilizing these APIs for business use cases where the consumer is authorizing the data, because it's going to put too much of an onus. I also think that HIPAA was not made for this era. It was made in 1996. This is paper records. There was no iPhone. There was no API ecosystem. It is not representative of where the world is going. So to say that we're now subject to HIPAA, which was essentially built for a different world, a paper-based world, it just seems it seems lazy to me, honestly.
Well, I don't disagree. I think we are still struggling to see how HIPAA applies in the world we live in today and how far it falls short of the kinds of situations that the panelists today have described. You know, we have dueling exchange standards. We have a number of things happening in the marketplace. And one of our audience members asks, you know, are QHINs going to fix this HIPAA problem? Are QHINs going to be the interoperability hubs for patient access using apps, or are we going to find it more direct to the particular sources that the patient wants to work with? Jen, you're shaking your head. I'm going to start with you on that first.
So I was very optimistic about, you know, when OneRecord we first started building it, we connected to Care Quality and Commonwealth. So we were actually much more of a, you know, using IHE transactions and being able to bring in CCDAs and parse them, right? But nobody would respond to us. And I sit on the steering committee for Care Quality, the operating committee for Commonwealth, and I'm on the board of Sequoia. So like, I know this space really well. What I'm seeing happening right now in the TEFCA landscape is, you know, there will be organizations who will say they will support individual access, but there are going to be other organizations who are still not going to respond to individual access in the TEFCA, in the Trusted Exchange Framework. Also, let's be real. We are still a year away from these QHINs really kind of being in a ready to go state where they can onboard participants. I think you're going to have some QHINs announcing early participants and doing some testing, but to see exchange at scale, if you look at Care Quality and Commonwealth, it's taken them 10 years to get to the scale that we have today. So we have this kind of, how long is it going to take for the QHINs and the participants to enroll in those QHINs to get to scale and exchange, right? So that means there has to be a certain amount of provider organizations participating for there to be a certain amount of value for the consumer. And we also know that there's just a lot of issues around patient matching when you're doing, and TEFCA is IHE based, right? There is an idea for what the FHIR IG is going to look like, but that is in its earliest forms. So I actually am more optimistic about state regional HIEs for giving consumers access to their data, because they actually they're named under Cures Act as an actor. So they have to comply with interoperability and information blocking final rule. Plus, they actually have data usage rights. So in my mind, when you connect to an HIE, if the wrong data goes to the wrong person through a consumer app, the HIE is responsible, not the provider organization. If it's on the QHIN level or even Cure Quality or Commonwealth, if the provider organization exposes the wrong data for a patient request, individual access, they're on the hook as a HIPAA breach, right? So it's just a question of where is the who's liable in that exchange. So that's why the FHIR APIs are so popular on the provider side, because there's a hard-coded ID that's attached to that person when they're going through that OAuth workflow. There's variables when you do it in a document-based query exchange at the health information network level or at the QHIN level. So I'm not as optimistic today, but like I have strong opinions loosely held, so I can be convinced otherwise.
Yeah, and I would say that I have similar caution and wait and see attitude around the interoperability through network-based exchange, particularly under the CCDA IHE format, because that's a very burdensome parsing and conversion that we would have to do. Meantime, as I think it was Chris saying, feeling very optimistic about a growing landscape of FHIR API endpoints being established, and TEFCA having a 3-year roadmap to FHIR with a facilitated FHIR pathway and a federated or a brokered FHIR pathway. What these basically mean, and the facilitated FHIR pathway I think is actually really encouraging, is that there would be certain services that QHINs could provide. It could be equivalent to a record locator service. You know how Jen was saying earlier, we can't find those service-based URLs. Well, enter the QHINs who could build and maintain a directory so that we can find them. That's value. And then once you find them, imagine for the patient access API use case that we have not just support with digital identity, IL2 credential service providers, but that it's federated so that OneRecord or b.well or another third-party application can use a credential service provider that is, in this case, Cantera certified, recognized certification entity, and that all of the data holders who are providing data through those API endpoints are basically saying we're trusting the trust framework service provider for digital identity, Cantera or Direct Trust or whomever, that they are doing the appropriate reviews on these credential service providers who are providing the IL2, AAL2 compliant identity proofing steps. And then imagine that they not only support patient portal credentials, but that they also allow for reauthentication at their API endpoints to an existing patient portal, existing digital credential. So now you've got a digital credential in your wallet as a patient who could authenticate and authorize those connections. And I see that as a more trusted and feasible pathway for the future. And I would also say, and go back to my comment earlier about the OCR really needing to step up and talk about when a third-party app in that circumstance, if they are also agreeing under some other kind of trust agreement, call it TEFCA or whatever, to perform their own checks, relevant checks to make sure that any data that comes through those API endpoints does not have mismatched records, alerts the data holder, deletes the data, does not redisclose it, all those appropriate steps, reducing the probability of data being compromised, that should be a safe harbor so that the data holder can feel more confident about making more data accessible through those endpoints.
Chris, you have a question online. You raised your hand. Do you want to pose the question to the panelists?
It's not really a question. Again, it's just I just want an observation. Just wanted to, temper the enthusiasm about, the ongoing flood of new FHIR APIs that are going to be available. My thought is that these new Fire-based APIs are likely going to be very use case driven and, serve the purpose of, fulfilling a very niche particular need until, until everyone becomes more comfortable with the whole Fire community. I don't foresee third-party apps being thrust in the middle for in the near future. That's just my observations. It seems to me like, these systems want to keep their data close as possible.
Thank
Chris,
you.
What are you're talking about the slide on the screen for HIPAA, or are you talking about?
I'm going
Yeah.
back to the first debate when we,
question.
we talked about in the very beginning, and then we just had mentioned that, there would be an ongoing, influx of Fire development in the provider and payer community. And, I guess my concern there is that that development is going to be really focused on particular use cases that are required to, either meet mandates or day-to-day operations or some other business-driven use cases, and not necessarily patient-facing use cases.
I also agree with you. That's where I see the internal units for most organizations is saying, okay, we've built this technology for compliance. How are we going to reuse it on the business side for us? And how do we make things operationally easier? Prior auth, you already mentioned that. I agree with you.
This is a fantastic discussion. If we get through 3 questions, I think we'll have an extremely successful hour. Why don't we move to question or topic number 3? And let's see what we have here. Health equity is at the top of the healthcare industry's mind now, whether from a consumer perspective, a payer perspective, a provider, or a regulator. And apps can play a role, at least we believe, in promoting health equity. What role do you see apps playing in this regard? Do the app developers in the room ask users to provide demographic or other applicable data directly to help assess equitable use? Do you leverage such data supplied via payer or provider data requests? Why don't I start, Jennifer, with you?
I don't have that much to say on this topic. It's not an area that I've explored a lot in promoting health equity, but I can say from a technical perspective, when a person connects to, when a user comes through OneRecord, we don't have any data on them, right? Until they connect to their data, whether via Fire APIs or one of those IAT transactions. But when they do connect via Fire API, we do get their demographics and we actually populate their user profile with that. And we were part of a work group where we did additional fields around like occupation and stuff like that. I do think that it'll be interesting to see as US CDI expands, what are those resources that will potentially become available via Fire APIs and for future versions, and will that be populating? But the first question is, where is it collected? So is it self-attested, or does it come from a provider or payer, and does it have provenance? So that's really how I think about it right now. I think it's in a very early stage in being able to collect that data from a covered entity.
Yeah, and I would say our orientation and context is slightly different from Jennifer's, because we do operate in a hybrid environment as both a business associate to our covered entity customers, as well as providing these PHR-like capabilities for our consumers and their patients or plan members. So I would say the question around health equity is really a use case. And so there has to be a business case driving the use case. And oftentimes, if for our customers that are operating under multiple ACOs, under ACO REACH, for example, where there is more of a primacy around health equity, then there is more of a focus in terms of the objectives in what they're trying to, in how they want to engage consumers through an application, and what they want to do with the data that they are getting through our platform in order to drive different outcomes. So population health, finding the data, demographic data that can be associated with, food deserts or health access deserts can mean that they will deliver programs through the application that prompt individuals into a particular setting so that they can actually address it. Because ultimately, it's not about, you need data in order to inform those targeted approaches, but what you really care about for health equity is getting people access to care. So we say data is table stakes, the war to be won is access to care. And so what we want to do is be able to make data or make access to care the key objective.
Graham, you're from your vantage point looking across these agencies, health equity has become a big goal in many respects for them. Can you talk a little bit about your perspective on this question?
Sure. Ours is a little bit higher level, but hopefully it's helpful that what we encounter sometimes when we go to Congress and advocate for the committees of jurisdiction to give political cover to CMS to cover remote physiologic monitoring, or if it's just to ensure that there's better access to digital health tools. Sometimes the pushback is, well, there's only certain classes of people that can access digital health tools because you have to have internet, you have to have a smartphone. And then there's a different kind of pushback that we get along the lines of, well, if you make telehealth more available, then folks that are disadvantaged might get pushed into that, and that would be the only means of access that they might have. But throughout the course of the pandemic, we have seen some of the data come out that shows that these fears or this pushback isn't as sort of supported by the evidence. And one example is that I guess it was Virginia's Medicaid department, DMAS, that collected demographic data about who was accessing virtual care modalities during the pandemic, Medicaid recipients. And what they found was, across all demographics, the usage went much higher, and in particular, African American beneficiaries were able to make use of telehealth at much higher rates than white counterparts, and that sort of indicated that they were able to access care where otherwise they wouldn't be able to during the pandemic, and they were not allowed to go and see the physicians in person. And so we're starting to see data that sort of indicates that access to digital health is equitable or helps enable more equitable access to care. And another example is maternal health and being able to use, for example, send patients home with blood pressure monitors that connect to smart devices to detect for preeclampsia and high blood pressure issues. And so, there's a growing body of evidence that's really kind of supportive of the notion that access to digital health helps equitable access to care.
Thank you. We're right on top of the hour, just about. And I wanted to continue our conversation as if we had an hour and a half. Are our panelists able to stay a little longer, or are you going with a hard stop at the top of the hour? Jen, I see you nodding. Graham,
I could stay. Yeah, I could stay for a little bit. Yep.
Jill, how about you?
Yes, I'm happy to be here.
Good. Excellent. That's terrific. That saves me a lot of anxiety and trepidation about how to get this done in the time that we have. Why don't we go to question number 4? Question number 4 asks the following. Accessibility is a major component of health equity. Can you speak to how you ensure your apps or your work with the agencies in question are addressing accessibility to all patients? Do you have special features for patients with specific types of accessibility issues? I think, Jennifer, this might be something that you, Jill, or you can address also for accessibility issues like visual impairments, developmental hand mobility, et cetera. How do you handle authentication for patients who can't access portals because of a disability?
Right. These are all challenges, and we have not found the silver bullets to solve for those challenges. But I will say if you think about the way we typically consume healthcare, we usually consume it as a family unit. So one of the core capabilities in our platform and our application is a concept called Health Circle, because we recognize that, like as I said at the top of our presentation, I am the lead caregiver for my 83-year-old mom. Guess who's actually on her phone doing these things more often, helping her navigate, schedule care, have communications with her doctors and things like that. So, and connecting her devices, the monitoring devices. So accessibility can often be done the human way by creating a permission structure that allows caregiving families and other close caregivers to be able to support a patient with those needs.
Thank you. Graham, what about from your perspective?
Yeah. So one of the things that our developers sort of look for, and part of the reason they like to sell through the app stores, is the developer tools they provide that have sort of development kits that enable accessibility features. And one of them is eye tracking, another is speech to text recognition. These sort of help ensure that they're at the ground floor of building the product, that there are accessibility features built in. And so they're kind of it's a little daunting when you're first starting out, I'm sure, and to make it useful for everybody. And so those developer tools have been pretty helpful. So that's one thing to note. I just saw a presentation from Google and Apple on the tools that they provide, and trying to make them sort of the challenge they have is sort of educating all developers on what kinds of tools are available and how to make them useful, how to plug in and use the APIs to make them part of the product, basically. But that's the goal, is to sort of make it available for everybody.
Jennifer.
From my perspective, something we've tried to do from the beginning is try and be as close as we can on the ADA compliance scale. Getting full like ADA compliance is actually very difficult. So in our user-centered design has really always been trying to figure out how to get as close as possible to test for that, whether it's using colors and the contrasts, writing accessible UX copy. There's some things that we don't do that really wouldn't fully help anyone who needs that kind of accessibility, but it's something, I think it's like a moving target that you as an organization should always be working on, and your designers and UI and front-end development team need to think about. But it's something that any organization that wants to participate in healthcare should have on their roadmap, because you're serving people with needs. And, could we do better? Yes. Do we try? Yes.
One of the issues that sort of permeates this discussion and others related to consumer engagement in the app economy is this kind of this chicken and egg question or problem, where plans and providers are saying the evidence of consumer engagement directly through digital tools to their healthcare is scant. We've had only X number of people pinging our Fire API or pinging our portal for information about price transparency or information about other aspects of care that consumers in our world would be keen to have. On the other end, we have these, this very sort of digitally focused, highly health aware community that really wants to advance this accessibility to health data, the use of consumer empowerment to drive improved care, and regulations are pushing in that direction. But we see this kind of impasse between, we're getting pushed up against something that the market doesn't seem to be ready for. Other people are saying the market is waiting for you to make it possible for them to be engaged. Could you talk a little bit, and Jen, I'll start with you. You raised your hand first. Could you talk a little bit about this impasse and how we might navigate our way through this?
Yeah, I mean, it's a little field of dreams. Build it and they will come, right? Well, it's
right.
Not the reality of how it works. The reality of how it works is here are very tangible steps. I think that's the right word. Concrete steps, things that provider organizations can do to help adoption. Number one, their patient portal pages. On their patient portal pages, Some providers, but this is like the 2% of the population, list, here are your patient portals. There should be a third-party application section. When providers list, here are the third-party applications that you can connect to get your data, those backlinks, you can track that through Google. We can see from our Google Analytics that most of our users are being driven from this health plan or provider organization's website where they list that. Most providers do not want to support or promote an application, but the ones that do are going to have a higher conversion rate. And it's not promoting, it's just saying, hey, here are the list of apps, b.well, OneRecord, Common Health, whatever you want to say, who have connected to the MyLinks, who have connected to the Fire APIs. That's very important, number one. Number two is, I'll give you a concrete example. There is a vendor who shall not be named, but a very big vendor who they have 500 unique Fire URLs, and I am having to go manually request by customer. It has taken me 5 months already. I started this on January 15th because that's when I first started this process. It is going to take me a very long time. So the more time it takes me to connect to a provider organization, the less adoption rate it is. I will say personally, we are having an issue in our application where we've connected to too many provider organizations at this point that our search functionality isn't working as well anymore. And what we're doing is we're going back into our databases to figure out how to promote the highest value provider organizations based off the most requests or based off name or what people are searching for. So we have a job as an app developer, but from a consumer adoption perspective, the majority of our users actually come through the App Store. So, you know, it depends on the company how much money they want to spend on ad sales. But a concrete thing providers and health plans can do today is on your patient portal page and your member portal page, list the applications that you can get your data from. And let's track that metric instead of just giving it a general commentary that there's no adoption. And also, provider APIs just came out January 1st. There's no concrete data. It's too short of a time span to track the access to data. Health plans, release your commercial data. We can have a different conversation.
Great. Jill, what are your thoughts about this impasse between if we build it, they will come, and no one's showing up, we're not going to build it until we have more evidence of adoption?
What I'm actually learning about now, I mean, and to Jen's point, I mean, we keep in a JIRA backlog. We know how long it's taken from the time we first register. You know, this is, leave aside how much time it might take for us to actually discover a developer portal or you know, documentation so that we can begin the registration process. But it will take, even now, 6-8 months. And when I have pinged the right people back, when I know who they are, I'm now learning, they're like, oh yes, we're going to unblock you, because they're suddenly realizing that they're getting some heat for not getting these connections completed. So Jen, thank you. I know you've been really loud here, but I mean, it has taken a village of third-party app developers getting loud, sometimes submitting comments and complaints to the regulators to get the attention we need to allow us to have the connections. We need the connections to demonstrate the value. It is a false narrative to say, well, we don't really have many people asking for connections. So what's the utility of supporting this capability? So it's a false premise, because we're here. There are many app developers in market trying to make those connections. And the whole premise of the 21st Century Cures Act rules was allow for the app development ecosystem to flourish and drive innovation. And that's, you know, that's what we're doing. You know, that's what we're building the rails for.
Graham, from your perspective, this impasse, what do you see?
I think what Jen and Jill have said is absolutely right. And we're hearing that more and more from our members, that there is a lot of data that their customers and consumers want access to that they're not necessarily able to get. And we've helped a couple of them, you know, draft complaints for the agency to start investigating. And so Yeah, I think there's a lot of demand. There's a lot that could be done. We had a briefing in one of the on the House side in Congress, and it was Congressman Schweikert, who's a big advocate for digital health, who said the data that you're passively collecting through all the sensors that you might have access to over the last couple of days is and this is overstatement, is more valuable than your entire health record that you might currently have access to right now. So a couple days worth of passive data versus your entire health record. But
that's ridiculous.
But point taken, though, that there is a lot of this data that's passively being collected that could be put to use and that could be useful. That is.
Well,
no.
I'll give you an example of something that really insulted me. My mom was given an application that connects with a wearable that she uses to monitor a health condition, and it's offered by a large pharma, right? And I go through the onboarding process, and they have a default authorization, like sign this authorization for, allowing us to use this information for marketing purposes. I say no. And then but then I don't see any acknowledgement for it. And then I go back into her account settings and I see that she has been coded as having signed it. I'm like, she didn't. I specifically would never let her do that. And so again, here's how caregivers participate in care. And so I wrote an email and I sent it to the relevant privacy office. It took 3 contacts and maybe 6 weeks before I got a response. So I guess my point is the industry can speak of the concerns of third-party app developers. Those third-party app developers include large pharma. It includes, other covered entities that are doing things that we're using metapixels, right? We know about how that's all going on. It's a very complicated area. I think a very healthy dose of humility is really important here. And we have to get centered on the fact that patient right of access is the 4th permitted use case under HIPAA now. And you have to be able to make that data accessible to patients.
I want to be sure that we open this up to our audience, and by all means, folks who are in our digital room, please speak up. You don't necessarily have to raise your hand. If you have questions or personal experiences accessing your health data or using apps to do so, we'd love to hear about it. So by all means, please jump into the conversation, tell us who you are, and we'll go from there. One of the premises of this interoperability forum is, MHDC, the Health Data Consortium's commitment to a patient-centered health data economy. And part of a patient-centered health data economy is the recognition that the value of data, Congressman Schweikert's assertion notwithstanding, that patient data is immensely valuable and is a source of tremendous economic gain for almost all parties except for patients, except for individual consumers. At the heart of this concept is the idea that, to use a probably not the most accurate term, we have models rights when it comes to our data. We have stewards in health systems and health plans who manage our data, but ultimately the use of those data, whether de-identified or not, will not be of any benefit unless it derives benefit directly for the consumer, including financial benefit. This is a concept where the idea of an economy moves the market to recognizing individual patients. Jill, starting with you, could you talk a little bit about the patient data economy and this concept of, the centricity or the centrality of the patient as an economic actor, an involved and participating actor in their health data system, and how that might evolve in the future?
Yeah, one is that a consumer should have the flexibility, to have their data, to consolidate their data, create a unified longitudinal record, and then to have it be portable. So one thing that Jen and I haven't really centered on is our active participation in the Karen Alliance, and that we are signatories to this Karen Alliance Code of Conduct. And it is founded on fair information practice principles. And some of those involve data deletion rights, portability rights, no sale or use of data for marketing without proactive express consent, no disclosure except for otherwise lawfully, to comply with law, no disclosures without consent. And so when I think about a value exchange, so OneRecord and b.well may have a different approach on delivering value, but we agree that that the imperative is for an app developer to deliver value. In our case, we work by providing a platform that allows our applications to be presented in a white labeled fashion for our covered entity customers so that they can consolidate this data, close the fragmentation gaps, and deliver better experiences. Those experiences could be convenience features like using the data on the back end to identify care gaps that align to HEDIS and other quality measure sets, and then drive people to action that they can close themselves, and even integrate things like scheduling or recommendations for particular digital health application tools that would be relevant for that individual. There are all sorts of different use cases that can sit on top of a unified longitudinal health record that can allow for a more personalized, engaged experience. And we can see a shift towards the shoppable healthcare consumer. We all have experience with Amazon and other digital platforms where we have a personalized shoppable experience, and we want to bring that to healthcare. So that's one way of thinking about the value exchange. And then I'll just also say, for some of our other fellow members of the Karen Alliance who are participating in things like clinical trial matching, they're accessing the data, consolidating health records in order to find the best recommendations for clinical trials or other patient support programs to help people with a severe disease try to get the care they need. And in those use cases, there's often a request of patients of whether they want to contribute their data back for research. I've also seen situations where there's actually a value exchange where a patient registry is created around a specific disease. And when that data on an aggregated basis is made available to pharma, for example, to support their clinical research and development, that there is a dollar exchange, and a part of that is returned to the contributors into those registries.
This
Graham.
is Janice.
Oh, go ahead, Janice. Go ahead.
Okay. I just wanted to make sure that we covered some of the stuff from Q&A that came in throughout that I told people we'd address in this bonus session.
Let's make sure we do that.
And the first thing that I'd like to do is follow up on something that Jennifer said very early on around authentication. And there was someone who wanted some clarification and just wanted to talk about, you mentioned something about using social, some type of social network in attached to the attached to the portal rather than a normal OAuth flow at some point, and the person got clarified twice. So I didn't catch you saying anything like that. So I just wanted to sort of see if you had anything to say about
I think
whether there are alternate methods other than OAuth that you are considering for authentication.
Yeah, I understand the question. So the big problem for consumers is, how do I prove who I am, right? It's the identity patient matching problem. So if a provider requests data from another provider and they get the wrong data on somebody, it's cool. Like they're covered on, they can just dispose of that data and it's covered under HIPAA, right? When a consumer requests their data, as soon as they request it, it's no longer covered by HIPAA, it falls into the FTC realm. So the three mechanisms consumers have to access their data today is write traditional medical records requests through the Health Information Department, fill out the form, request your records, covered under HIPAA, time and material costs and the time span to request your records. The second method is this OAuth workflow, which what OAuth is technical standard. It's a technical thing underneath the Smart App Launch framework that is mandated under Cures Act. And basically what it is because I, as a patient, have a MyChart, those credentials for my MyChart can be reused to hit the authorization server and the FHIR server to pull back my data. So the provider organization or the health plan are essentially assigning a set of credentials like a username and password that are reusable for a technical workflow for me to access my data via an API or access my data via my MyChart. The other workflow, which we've kind of touched upon, is this concept in a traditional document-based exchange world. So pulling CCDAs using standards like XCA and XCPD, I can use my demographics after I've gone through an identity proofing event with companies like Clear, ID.me, LexisNexis, TransUnion, Persona, whatever. And they have verified that I am who I say I am. Like when you go to the airport and you see those Clear things, they have my biometrics, my whatever the things are in my eyes. And they have verified that this is exactly who I am. And then you use those demographics and you send them to the responding gateway. That is a demographic-based match for patient access, which is a very low response rate right now. Jill kind of mentioned it. It's about a 2 to 5% response rate because there's a fear right now on the match. And there's also, this is something that people don't talk a lot about, but even though Clear or Lexis or whoever has given me clean data about me to then send to a health system, the health system might have bad data about me. Like they might have incomplete demographic information. So it makes it even harder for them to do the match. In an ideal world, a patient should never have to click through 10 portals to aggregate all their data. They should be able to query a national network and get all their data, just like I use my cell phone to call any network across the country to connect to any one of my friends, not just across the country, across the world. But that kind of, that user experience isn't supported at scale today. So that was what I was referencing. And if I made it more complicated, you can reach out to me on LinkedIn. I'll talk to you about it.
Okay, great, thanks. That's what I had read, and I thought, anyway, let's move on to the next question that we got from folks. TEFCA and other national networks focus primarily on query-based interactions. That's limiting. So how do you see us engaging in other types of exchange, such as push updates and ADT, patient corrections that might require FHIR write, and other non-query-based transactions?
Oh, well, I'll start with FHIR write. I would love to have FHIR write, but those patient access APIs have read-only access. So that's back to you providers and payers to open that up. If we were able to write back, we can actually probably contribute a lot to health equity and to all the bigger questions about, the consumer actually giving the information between those episodes of care of what's happening in their lives. Usually to get that right access, you have to have some sort of BAA or some sort of relationship with the covered entity. So, the government officials are on the line. I think this is a good idea.
There are a lot of complex clinical workflows that have to be integrated into that. And just also the approach for taking a write API. So I won't, I'll lose my thread quickly on this, but there is a standard called Smart Health Links, which was used for the vaccine credentials, right? And so the idea is that using a QR scan, you can actually get an authoritative snippet of data and know its source and be able to authenticate at source in order to validate that that's good data. So in a more limited context on write capabilities, if you know that one doctor has the right information that needs to be written into the record of another provider who's using a different EMR, and you allow the patient who already does this by getting on the phone and sending an email or sending a fax or bringing it to the office, if instead you allow that the patient to mediate the exchange of data of an authoritative snippet of data using a QR code, using the Smart Health standard, then that might be able to at least prove out the viability of write API capability.
Great.
to the other part of that ADT and document-based care exchange, I think that from a treatment perspective, the national networks serve treatment well. So it's just a question of how can the national networks or future QHINs serve patients and payers well. Payers are super underrepresented. So it's just a question of who wants to play nice together.
Okay. Speaking of underrepresented, there was a question about who are the most underrepresented users and consumers of health information and who are the most overrepresented. And I would clarify that I assume we're talking about through third party.
For us, just looking at the average users demographics, definitely people who are not consuming healthcare. So that under 30 age group, like they haven't had any major medical life events yet. You know, the way you consume healthcare right now is, you know, like adult, you know, as a baby through a certain point in adolescence, and then there's this gap, right between college, like you're just using it for what you need to submit to go to college, and then post-college. So as soon as you start having any sort of diagnoses or start family planning, you know, women are going to have a bigger use case because of that childbearing age. And then, I mean, a lot of our users are on the older side, just because they consume a lot of healthcare. And, you know, I think by the time I hit the Medicare, Medicaid, or Medicare age, like I'm pretty tech savvy, so I'm going to look for tools. I have no tolerance for waiting for anything these days.
Anyone else want to take a stab at that?
I would say it's very context driven, based on the users that our different customers are looking to target. So an example of a customer that has a large ACO population that they're looking to target. So they'll utilize the health circle and they'll do messaging so that even if it's not the Medicare beneficiary population, but maybe a family member, then that is sort of considered a win. Others are also oftentimes rolling out initially with employees. And so you're talking about a workforce that has some exposure and facility with digital. When you're looking at a more mass market sort of consumer retail kind of population, we then start seeing more differentiation around personas, because there's some people who are just reluctant, you know, they don't trust any application. And then there are those that are just more trusting, or they have a more immediate need that they where the data is relevant to them. So it's just very difficult to for us in our data to be able to offer those demographic breakdowns.
Right. Well, I think it's 10:28, so I'm going to pass things back to Denny for wrap up.
Thank you,
Thank you,
Janice.
guys.
Why don't we go to the next page in our presentation and tell folks a little bit about what's coming up next month. We're very excited to have Lorraine Dew from CMS and Patrick Murda, the Chief Platform Architect from Behavior, joining us to talk about essentials for interoperability. We start driving into the technology standards for data and exchange, and understanding from a high level, from the perspective of a regulator and a leading architect, how these specific essentials will be rolled out. So we encourage you to join us. This is an ongoing conversation. We're excited about having it. Lastly, I want to make sure that folks participate in the poll that will be coming up when our discussion ends today. It's very brief. Just take a few moments to do that. We appreciate your letting us know about today's conversation. And lastly, on behalf of the Massachusetts Health Data Consortium and our community, I want to thank Jill DeGraff, Graham Dufault, and Jennifer Blumenthal for a really thought-provoking and tremendously informative discussion. We're going to be seeing you more. We know that. We can tell by what you're telling us and who you are and what you do that we have only started this conversation. So we're very excited to continue that with you. And I want to thank you for participating. And I want to thank our audience for joining us today. Please tell us about your experience on social media. Let us know what you thought about the survey. And thanks to our participants and our expert panel. With that, we will bid you adieu, and we're adjourned.
Thank you.
Thank you all.